Good morning, distinguished guests, esteemed speakers, and valued participants. I am Ananta Sharma, a member of the Global India AI Summit team at the Ministry of Electronics and Information Technology, Government of India. It is my honor to welcome you to the GPAI convening on global health and AI. Today, we have gathered here at Bharat Mandapam, New Delhi, to embark on an insightful journey discussing the integration of AI into healthcare, particularly focusing on the unique challenges and opportunities within the Global South. As we know, the Global Partnership on Artificial Intelligence is a multi-stakeholder initiative that unites leading experts from science, industry, civil society, international organizations, and government. Our shared vision is to promote trustworthy AI while addressing pressing global challenges such as global health, which is a priority area for GPAI. India, as the lead chair for 2024, is proud to spearhead numerous GPAI initiatives, including today's convening. This event aims to provide an opportunity for AI practitioners and policymakers to showcase their work, deliberate on the unique context and challenges of integrating AI in healthcare, and develop potential new directions for GPAI's future endeavors. Today, our focus will be on three critical pillars identified during our recent domestic consultation, that is, data quality and accessibility, digital infrastructure, and regulatory and legal frameworks. These issues are particularly relevant in the context of the Global South, where high quality, reliable data and robust digital infrastructure are often lacking. Through our discussions, we aim to understand global viewpoints, learn from best practices, and explore how these can be adapted to improve AI implementation in low resource settings. Before we begin, I would like to introduce our distinguished speakers and panelists for today's convening. We are privileged to have with us Dr. Karthik Adappa, Regional Advisor for Digital Health, WHO. Dr. Adappa is a renowned physician scientist with extensive experience in digital health, public health, and AI interventions. We also have with us Mr. Sameer Kanwar, Director of Digital Health, India and South Asia, who will be moderating several discussions for today's convening. Our panelists include Ms. Megha Chaudhary, Advisor at Brainsight AI, Dr. Sanjay Sareen, Vice President of Access at Find, Mr. Mihir Kulkarni, ML Scientist at Vadhwani AI, Dr. Mona Duggal, Assistant Professor at PGIMER Chandigarh, Ms. Jo Agarwal, Co-founder and CEO of Vaisa, Ms. Gitanjali Radhakrishnan, Founder and CEO and MD of Adiuvo Diagnostics Private Limited, Dr. Basant Garg, Additional CEO at the National Health Authority, Sri Madhukar Bhagat, Joint Secretary, Ministry of Health and Family Welfare, Mr. Ankit Modi, Head of Products and founding member at Cure AI, Professor Anurag Agarwal, Head of Koita Center for Digital Health at Ashoka University and Dean of Biosciences and Health Research, Mr. Nilay Verma, co-founder of Primus Partners, who is currently running a little late. I would now like to request our keynote speaker, Dr. Karthik Adappa, to kindly begin with the session.
Well, we probably don't still have AI to get us the clicker, so I'll get started as we get the to get the lay of the land. Essentially, this has been an effort where we've done a domestic virtual consultation, trying to identify what really are the gaps that we have in using AI in the Global South. We've had one virtual consultation. We've been able to identify three different pillars. That's something which Ananta just talked about. I want to use this opportunity to kind of talk a little bit more about deciding a framework on how do we really think about this a little more in greater detail. So what I want to do is first I want to talk about what is the widening chasm between the global north and global south in AI. Talk very broadly what are the challenges that global south has in using AI, and then use three different things. Use a generalized AI lifecycle, and then embed that with some core principles for trustworthy AI, and then develop a framework for identifying challenges in using AI for health. Because we essentially have a lot of wonderful stakeholders. I'm only hoping that as the organizing committee, we want to kind of think a little more deeply and essentially come out with an AI playbook. So that's our eventual goal, and this consultation is an approach by which we want to hear variety of stakeholders. So globally, what we are essentially seeing is there's a widening chasm that we have. Probably it's better if I stand. So in terms of a network readiness, this is essentially an index that talks about how are digital technologies evolving globally. And what we actually see is that the rich countries, the wealthier countries are the ones which are able to actually utilize digital health technologies. But there are, yes, certain low and middle income countries that are making progress as well. Now, apart from that, when we then go into a little more into AI research, it's not a surprise that most of the top 10 countries are essentially from the Western or the European countries or the North Americas. We just have a splinter with India and China contributing here. But when you look into funding for AI research, that's when you see that countries like China and Brazil from the global south are representing. And it's otherwise, again, very traditional in terms of the Western and the North Americas and the UK, and this shouldn't really surprise us. But let's go into a little more into how is the global space in terms of responsible AI coming out. What is very interesting is this a very recent report that tried to look into how is the global index on responsible AI across the world. This essentially looks into all the 138 economies across 3 different dimensions, and it looks into 3 broad pillars. And what you'll actually see on this is most of the countries above 75 are essentially in North America, Europe, and Australia, whereas most of the global south is in scores less than 50. And this should, again, not really surprise us. Now, what is also very interesting is when you look into what is the potential gain that different countries around the world as regions are likely to have, again, it predicts that China is potentially going to get about 26% is going to contribute. China and the US or the North America alone are going to capture 70% of the markets. The benefit that you would gain in AI is essentially going to be between these 2 regions of the world. So with this being there, but how about our users? While we see now very clearly, whether it is in terms of funding, whether it is in terms of research, whether it is in terms of the basic infrastructure, you can certainly see the global not taking an upfront lead. But in terms of the country share by the users, you'd see very interestingly that the global south, there are potentially the large number of users using these large language models. So our users are continuously using AI, even as we speak, and so therefore the AI adoption scores are also fairly high. So here is a time for us to think, what do we then do? So I want to kind of, when we think very broadly, and this is something which we said from the global consultation, you would talk about this as very broad challenges for AI in healthcare. For example, we would all talk about, are we really addressing our local priorities? Are we looking to very contextual, specific healthcare problems that are unique to our area? And we also recognize the fact that we have data scarcity and quality issues. We, of course, have infrastructure issues. And then there are a lot of contextual differences between how you would implement AI within a high resource setting versus low resource setting. There are ethical concerns. We recognize a lack of workforce capacity, regulatory frameworks, and of course, what about the cost and sustainability? Are these AI solutions that are coming out as splinters in our ecosystem, are they really sustainable in the long run? What about the cultural acceptance? Are our AI solutions really trustworthy enough? What about interoperability issues? So you would see that these are the broad challenges that anybody would talk about. That is generally been thinking. But let's get a little more deeper into what is essentially the gender equitability, and especially in the AI in the global south. You certainly see a large amount of data gaps for marginalized communities. Are we having data sets that would really think about specifically the underprivileged and the marginalized societies? Do we have an understanding how gender inequities manifest in our data? Are we thinking on those lines? What about the danger of being gender blind? And most importantly, do we really capture gender identity in our variety of gender identities in our data? What about the lack of transparency leading to trust gaps? So essentially, this is again a broad framework. So what I want to do is I want to kind of think about a very high-level AI life cycle. So this is something which would be common to all of you, but just for the sake of others, what typically you would do as an AI machine learning scientist is you would first think about defining a problem, designing the AI system for that specific problem, engineer an AI solution for that, look into assessing it. You would go into a clinical setup, you would go to a lab, assess it, and then you would pilot it. You would think about what is the right kind of clinical environment where I can pilot, and then you would try and deploy and monitor it because you want to look into seeing if the efficacy of the tool is a sustainable one. So this is a very generalized life cycle for any AI platform or any AI solution. Now, these are some solutions. These are some core principles for any trustworthy AI. Now, anything that you would want to do, you'd want it to be useful to the user. You want it to be used in terms of usability, in terms of efficacy, you would want to think about that. You want to think, is our solution really fair? Is it equitable? Is it safe? Is it reliable? And then we want to think about the transparency. So every model that you build, are you essentially putting out the model information out? So is it transparent enough? Is it intelligible enough? And are the ones who are building this model, are they accountable to the real stakeholders and the users? And then you, of course, would want to think about this overarching guardrail of security and privacy. Now, if that is the general life cycle, what we want to do is think about a framework. Collectively, what we do really well is bring out a variety of challenges. But what I want to do is I want to use this few minutes to talk about a framework, which is essentially saying, okay, if these are the general life cycle for an AI, and then we know that these could be the core principles, and of course we can expand upon the core principles, but then we also want to think about who are those stakeholders. Are we having enough stakeholders here, variety of stakeholders? Are we listening to the patients? Are we capturing what our providers want? Do we have clinicians here as a part of the stakeholder engagement? We need to, of course, involve industry, and I'm glad there are a lot of industry partners here. We have academia well represented. What about the regulatory authorities, our healthcare organizations, innovators, nonprofits, tech developers? So now here is a very interesting scenario where you know what you want to do in a typical AI life cycle. You also know what are the core principles that you want to include, and then you want to have a conversation with these key stakeholders. And essentially the goal is to put all three of them together. And then what you want to do is you want to ensure that you're learning, it's a learning health system. So you're constantly learning off each other. So what I want to do is as experts are here, I want us to think and use this framework at every stage. What is the core principle that we're trying to tackle? At what stage of the AI life cycle are we thinking about? And how do different perspectives of different stakeholders, how do we capture all their key stakeholder perspectives? Now, to just give one specific example, now just let's go to the stage of defining a problem and a plan. Now, if you think about the core principle of usability, usefulness, and efficacy, one of the first questions that we want to ask is, are our AI solutions effectively being integrated into clinical workflows? Now, think about fairness and equity. Are we trying to really avoid discrimination against specific socio-demographic groups? Are our organizations having a bias monitoring and mitigation strategy? What is that as gold standard that different organizations have? Now, in terms of safety and reliability, do our organizations have a risk management SOP? Are we thinking clearly who should own the responsibility for a safety, efficacious, and the performance of the AI solutions? Is it going to be the developer? Is it going to be the organization that's actually implementing it? Or is it who in the stakeholders is going to take responsibility for that? In terms of transparency, how do we make this model information accessible to all stakeholders? Most importantly, how do we communicate risk to our end users? So there are some very key questions that we want all of us to deliberate upon, and I don't think we have all the answers. But essentially, this consultation is a process where we want to help our country build an AI playbook. And therefore, I want to kind of lay the ground for all us to deliberate using a specific framework. And of course, it does not have to follow this, but I want to kind of share that one of the most fundamental things is we're all sitting at this important movement where there's a huge paradigm shift on the way AI is being used. Now, how do we therefore bring our solutions to our communities? How do we bring it to our patients in a way that is equitable, that is safe, and also science-based? So I will pause for now, and I'm really looking forward to wonderful conversations on this from a variety of experts that we have. Thank you.
Thank you, Dr. Adappa. We now have Shri Madhukar Bhagat, who will be talking about the integration of AI into healthcare from a government's perspective.
Thanks a lot. And at the outset, let me say that it's a pleasure to be here. Honorable moderator, my panelists, and illustrious participants who are present over here. The focus of what I'm going to say in brief is essentially going to be in AI and health, specifically the government health sector perspective. So the pillars have been defined, and let me congratulate, first of all, Karthik on an excellent opening session the keynote which has set the ball rolling. We are talking about the various pillars, and I'll be talking about more specifically what are the poignant areas, specifically from the AI, health, and government perspective. But when I talk about government perspective, quite a few of these elements will be present in other areas of private sector. Quite a few elements of these will be present having a universal presence as well. So the first thing is defining data standards. When we talk about data quality and accessibility, a very important element is what should be our data standards. And if I talk from the government experience perspective, then each project is very unique, and at the outset we have to look at to what is the data standard. We should not be looking only from the perspective of the project or a specific project being an end in itself, but it may require a continuation. And if we want to make use of the synergy of research, then what work has been done on a particular project has to be carried forward. And that's why data quality and accessibility is important, but defining data standards becomes extremely important. For example, I'm doing a project on diabetic retinopathy, then what has to be the standards? They has to be defined. And not only the standards as far as the core disease is concerned or the health parameters are concerned, what are going to be the parameters as far as the other accessories, the measuring instruments, and other parameters that would be acceptable as far as implementation of the project is concerned. Data quality is always, extremely important. Interoperability. Standards have to be looked into and quality has to be ensured so that we have an interoperability. And as I said, that research and applications do not become silos in themselves, but they offer a platform where further work can be carried forward. Institutional coordination for data access. Well, now as far as government sector is concerned, how can we coordinate? When I talk about institutions, these institutions are government as well as private sector. Can we cooperate with each other? Like in government, we have an MOU with the Ministry of Health, with Vadvani AI, which is also present over here, a private sector organization which is providing us the platform. And we have the institutions of excellence, which includes the AIIMS Delhi, the PGI Chandigarh, whose representatives are over here, and AIIMS Rishikesh, which all the three are coordinating. So institutional coordination. But institutional coordination is also important not just for launching a project, but also for access to data. It's not necessary that one institutions like AIIMS Delhi may be having all the data, and why we not have a look at the PGI Chandigarh or maybe a private sector hospital. Can we enlarge our scope of cooperation? That is the principle that we have to think about. Common data repositories. Now, how do I use data collected over in a particular research so that we have a common data repository? And I said, this will help the research and the application not to be limited to itself. Support system, now extremely important. When we are talking about a project, we are only talking about the IT platform. Yes, it's very important, and that is given. We are talking about the data, extremely important. But when we are talking about the health sector, we also have to be very conscious that the doctors are hard pressed for time. They are the drivers, they are the movers and shakers. And many support systems will be required. One of them can be the human resource. Who's going to enter the data? Huge amount of data has to be entered. AI is not going to enter the data directly. And at the end of it, there is a human being, a data entry operator, for example, who has to take the medical data which is available, who has to feed it into systems which is hungry for data. Regulatory framework was another pillar. I'm briefly touching upon it. When I talk about regulatory framework, again, the issue of standards are going to come. There are going to be regulatory framework which are defining certain standards. Regulatory framework will also take into account to some extent the quality of the data. For example, if I take the DPDP Act, which has come recently, we are talking about fiduciary relationship, we are talking about the anonymity principles, whose responsibility is what. And then in that particular case, when we are defining standards, when we are talking about data quality, we also have to take into account the regulatory framework. For example, we are talking about medical data, we are talking about ABHA. then we are talking about Aadhaar also. If you're talking about Aadhaar, then we are talking also about the UIDAI Act and the concept of India. Because there are multiple layers of identity which is built in data. And then we also have to anonymize data. How do we do that? Common data repository support systems, again, they are also a part of our regulatory framework, because if we are talking about data repositories, then we are also talking about sharing of data, whom we can share data with, what is the nature of that data, the principles of confidentiality, they apply. What also extremely becomes very relevant is not only just privacy of data, but also security of data. And this is one area we often tend to overlook when we are lost in the glitz and glamour of AI, that data security is extremely important. What is going to be the standards for data security? The accepted industry standards, is it going to be sufficient? The experts have to think about it. And I always try, coming from a background where I do security audits for other countries, I always try to emphasize that we have to give a thought at the very nascent stage as to, are the standards for data security, cyber security, access controls are sufficient for the health sector? When I talk about financial data, coming from the background of income tax, that data is extremely relevant when it is today. 10 years down the line, when I talk about the banking data, how relevant is that 10-year-old data? It is relevant, but the relevance is decreasing. But when I talk about the health sector, if somebody is able to get 10 years old record of a patient and continuously, is it relevant? Or has the relevance increased? I have to ask that question. And then the issue of data privacy, that becomes relevant. What becomes relevant is, an individual is there. His health record has ramifications for his life, for his insurance, for his work, for his privacy, and not just, as I compared, for his finances, which it has relevance. And therefore, what are going to be the security standards, where before I talk about the issue of sharing of data? Now let me talk about specific government experience in brief, so it sets the ball rolling as to what the government is doing. So as I mentioned earlier, we have developed 3 centers of excellence as far as the work of AI in health is concerned. We have AIIMS Delhi, we have the PGI Chandigarh, we have AIIMS Rishikesh. We have a tripartite MOU, actually it's between the Ministry of Health and between the Vadvani AI, but that takes into account the various centers of excellence as to what work is being done by them. Now let me give you a look as to what are the various projects which we have already embarked upon. Many of them are in different stages of development. For example, we have the clinical disease support system, which is already integrated with our telemedicine platform, which is called eSanjeevani, which is already helping the various doctors at the field level in making a diagnosis. The media disease surveillance IHI platform, which is helping in crawling through the web and catching hold of the various news about the eruption of the various diseases and developing it into, is there a possibility of outbreak of a particular disease? What should be the alert level? And all those, I'm just giving in brief. Diabetic retinopathy, a very interesting project where, because of damage to the nerves and retinopathy taking place, how we can make use of the images to help the doctors understand as to how much is the progress of the disease. Prediction of adverse TB outcomes or the various lung conditions, cough against TB, line probe assay, dermatology, oral cancer, alcoholic hepatitis, radiology, ASHA, helping the ASHA workers at the ground level. These are some of the various projects which the government has embarked upon. These are at various levels of development. But let me tell you one thing which I feel is extremely important. The work of AI is not just for the purposes of brainstorming. The work of AI is not just for the purposes of development of a proof of concept. The work of AI has to be application oriented, especially for a country like India, especially for the government sector. And the reason being, that, look, there are 3 Ds which govern the health sector of India and especially AI. The first D, I would say, is the huge demand. There is a great divide. The divide is across demography, and that divide is, we are very conscious of the fact that the lack of health penetration which we have. The government has made lots of effort, the private sector has come up with its own effort, but still the ratio of the doctors to patient, as we can see in India, is still on the adverse side. And we would like to make use of AI solutions to bridge that divide to the extent possible. The demography. India is a country with huge demography, diverse demography, and that is ideally suited as far as the health sector is concerned. And of course, we have data, huge data, which we have the advantage of. So, as far as health sector, government sector, India is concerned, I would say we are making the right moves, but we have miles to go. Thank you very much.
Thank you, sir, for your enlightening address. Now I would like to hand over the session to Mr. Sameer Kanwar, Director of Digital Health for India and South Asia at PATH, who will be moderating our discussions today. Over to you, sir.
Thanks, Ananda. Thank you so much. I think probably I have a very little role to play now after these 2 presentations, actually, because largely that was the focus area of the entire discussion. So what I'll do is quickly probably just summarize as to what has been covered and just drive the discussions, because as I see we have exactly about 57 minutes, and I'll take 2 of them, so that leaves us with 55. Quickly, we've talked about data, and in data we are looking at the availability, reliability, and the accessibility to data. We are looking at the privacy concerns around data. We are also looking at the overall quality of data. We've said we've got huge amount of data, but we need to look at the quality. We need also to look at the continuum availability of a continuum of data in terms when we look at AI models to be able to use them, and the availability of data in public. All right. So public data sets, I think, is a huge call, and a huge cry which comes from the private sector always. Right. We talked about regulatory frameworks, and probably also we need to include the validation frameworks, and I'm sure we've got experts in the room who's going to talk about it. How do we validate and who certifies, right, these products? Everybody claims today in the private sector, I have 80% efficiency, I have 90% efficiency. Which is the institution? What is the institutional framework which is available? And Dr. Madhukar talked about the institutional framework in terms of the center of excellences being set up in India, right? Can those be the places where we could look at certifications coming out in terms of who's validating those products which we are talking about, right? What are the data sets which have been used? What are the gold standard data sets available against which the algorithms need to be tested out, right? I mean, because I think largely what we are looking at is there's a huge trust deficit when we look at AI, when we look at the private sector, and when we look at the PPP model, which we keep talking about, private-public partnership. It doesn't happen in the AI world is largely because of the trust issue. How do we, together as the stakeholder community, build that trust around it, right, to be able to work in the same space, right? Because technology is going to come from the private sector. There's absolutely no doubt about it, right? The scale lies in the public health sector. Who and how do we bridge that gap, I think, is what probably we should be looking at when we are looking at Global South. And what Dr. Karthik Adappa mentioned very clearly was, how can we look at the center of gravity, if I may call that, to shift of technology from the north to the south, because that's where the scale is, that's where the requirement is, that also is the place, fortunately, where technology is now coming from, post-COVID. So how can we leverage the sets which are available in India as to be able to lead that discussion going forward globally? Lastly, also, probably one aspect which may need to focus on and part of the discussions is how do we build evidence? Because that's probably in the health sector is a crucial piece which is as of now missing as to how do I build evidence for use of AI, evidence for use of digital health, evidence for use of technology, right? So with this small summary, I'll move to you, Sanjay, because you've got probably the largest amount of experience in this room, if I may say so, in terms of the diagnostic space. And you've been working with global organizations with multiple countries across the globe, and you work right from the strategy down till the implementation level as far as diagnostic devices are concerned. And there's a huge amount which is happening there in terms of building of hardware as well as the softer pieces of algorithms being used on diagnostic devices. Where do you perceive this, these AI-enabled diagnostics, if I may call so, moving forward? What's the scale which is available, and what's the impact which you foresee coming from these devices being implemented? And if you may just spend some time in diversifying into what is going to happen in the private space and what is the applicability in the public space for these. Thank you.
Thanks, Samir, and a very good afternoon to everyone. So yes, I think rapid advancement of artificial intelligence today has the potential to transform access to screening and diagnostic technologies, both in the public and the private sector. And in fact, we're already seeing that AI-based solutions have, the potential to empower individuals to take informed decisions on, where to get tested, how to get tested, and when to get tested. And we saw this, for example, during the pandemic. We started with the PCR-based solutions where everyone was flocking to the labs, and then how the rapid diagnostics or the RAT test, which became available, and finally the self-test becoming available, which sort of gave the individuals, agency over their well-being, that, they have the power to get themselves tested, But then again, I think there were challenges, specifically with how to read those tests, and how to make sure that the data gets transmitted to the likes of Indian Council of Medical Research and the Ministry of Health, so that you're able to sort of, look at it from a surveillance standpoint. And that is where I think AI-enabled apps, which can allow the community healthcare workers as well as, the patients or individuals like us to be able to read those solutions, and in the security of the homes have a lot of potential. Then I think AI-based solutions, we are already seeing that they have a huge potential to sort of enable task shifting. We are seeing this very much in the space of AI CAD, enabled X-rays. There are handheld machines which are now available, and the government of India is, very actively pushing the use of AI. And under the Global Fund C19RM mechanism, there is a whole bunch of handheld X-ray machines which are being procured by the government of India. And they have the potential to actually enable the community healthcare workers to not only screen for tuberculosis, but also for other chronic respiratory diseases in community health settings. And then more importantly, not just screen, but also, the AI-enabled software is also able to provide them with some sort of an interpretation basis which they can either triage, or do some level of diagnosis at that level. Then AI-enabled cough apps. I think Mr. Bhagat spoke about that, and so did Karthik. That these again have the potential of enabling triaging at homes, at communities, as well as at the primary healthcare levels. And then talking a little bit about surveillance, the government, for example, is investing a lot. There is a fantastic National Public Health Observatory that has been, built at the ministry, which, I think of last count, if I'm correct, screening for about 36 diseases, both communicable and non-communicable. So I think AI-enabled interoperability solutions today have the power to strengthen surveillance by very rapidly processing, unstructured data, and then enabling the policymakers to make some informed decisions on, let's say, outbreak management or pandemic preparedness, among other things. And I think with over 3/4 of the US FDA's AI ML medical devices today focused on screening and diagnostic solutions, we feel that there is a lot of innovation that is happening in this space, and this is something which is going to rapidly, keep on increasing. Having said that, it is critical that, in order to fully realize the potential of AI-based solutions, it is critical to ensure the availability of gold standard data sets. And I think Honorable Minister in the inaugural session, he spoke about that the government is going to look at, making these data sets available. So I think that is something which is absolutely critical as we sort of move forward. And it is needed, not just for product development, but also for product evaluation and also for post-deployment monitoring. But there are some impediments, in terms of, these data sets being available. There is obviously, limited guidance on the development and management of these data sets. Then I think Mr. Bhagat, you spoke about, data governance. So I think the governance mechanisms, they need to be strengthened to make sure that the privacy of the individuals is protected, and there are some sort of standards that can be sort of made available. And last but not the least, there is an absence, or I would say inadequate and streamlined regulatory approaches to make sure that these data sets can be used in a responsible manner. So maybe I'll stop there, Samir, but happy to take on more questions.
Thank you so much. I think, wonderful, Sanjay, and that's what probably I was expecting as well, coming from your end. In terms of, I think you raised important points in terms of task shifting and I think use of unstructured data, and probably I'll have a question for Mahir when we come to that, right? You talked about data sensitivity and specificity, I think, in the last convening which we had in June, and probably there's a connect there. We'll talk about it more. And of course, talked about screening at population level, which probably is the public health use case, I think, for all these technologies, and of course, the decision making and the gold standards data and regulatory frameworks, which we are already talking about. I'll shift the focus a bit and coming on to you, Megha, in terms of, you work in a very, very diverse space of brain mapping, right? And I'm sure, I'm not a doctor, so I'm sure, but there would be a requirement of, very specific and contextualized data sets in terms of demographies, in terms of age-related, data available. So what has been your experience globally as well as, let's say, in the global south, in terms of availability of these data sets, and how much of a struggle it has been to be able to, develop and train your algorithms using the existing set of data which you have?
Great. Thanks for the question, Samir. And I'll start contextualizing my answer with a little bit of like a primer on what BrainSight AI does. So in a nutshell, what we're doing is creating Google Maps for the brain. There's very little that's understood, and the intent is to enable clinicians to get a whole brain point of view that improves the ability for better prognosis, better diagnostic capabilities. This in itself as a process, so I'll just focus on what the data requirements are, and then maybe what are some gaps within the system already. At a fundamental level, if I had to say that I had to map everybody's brain, even in this room today, there are maybe 3 parameters that are of absolute crucial importance. The first is at a geographic demographic level called brain atlases. So we have Asian brain atlases, we have Caucasian brain atlases. We also now increasingly have Indian brain atlases, but just the quantum and the availability of that is something that needs to be augmented. So that's also the foundational block for a lot of the studies. The second level is cohort based. So this is where we get into demography, we get into brain morphology, questions about how does epilepsy, what does an epileptic brain look like? How is it different from the point of view of a normal standardized brain set? And this itself for us as a startup competing from a global south first point of view is to say that we actually have the opportunity to build the largest data repositories, and a lot of the intervention here could be about earlier, readier access. So we did speak about PPP models, we did speak about a lot of the interventions that come in here, but from our perspective, a lot of the challenge really lies in terms of creating the right kind of incentives for different players in the ecosystem. There are a lot of front runners in India already that have this data. So clinicians, research first in institutions, can incentives be aligned better to ensure that data sets for these are actually shared with us at very early stages, and we are also able to then quadruple that advantage manyfold. Lastly, individual data parameters. So even within a cohort, I may have a very, very different morphology because of my clinical history. And sourcing that currently from hospitals, from individual patient sets, there's a lot that comes in terms of standardizing technical parameters from scan-based perspectives. We have spoken about patient privacy, who owns that data, how do we ensure that that remains absolutely sacrosanct across the value chain. So just to kind of summarize it, I would say for us, the question on availability to a great extent would be a joint intervention on how do we create more investment to actually get a lot of India-based data focus going within the brain space. Largely, the atlases themselves do take a lot of intervention to get built. So maybe there can be some concerted efforts there. The second part on access, can there be better incentives that are actually aligning a lot of the stakeholders even within the defined ecosystems that we are looking at and build from there on. I'll stop here, and I'm sure we can kind of come back to this with different perspectives on the table. Thank you so much.
Thanks, Megha. I think this was really educative, actually, if I may say so, at least for me. I had no idea about these kind of data sets and the requirements around it. And probably I do have a sub-question for you as well as other private sector players in the room, and I'll come to that if we have time in the end. Dr. Basant, I'll move on to you very quickly. You've, as the helm of NHA, you've been at the forefront of, getting the sectorial DPIs for health up and running in the country, and you are now probably well placed to move into the maintenance mode where you will be probably evolving and taking it forward. From your perspective, having done those building blocks for digital health, where do you think it positions us in terms of very quickly being able to use them for artificial intelligence use, and what is the role which you think these building blocks play when we look at technologies like AI very quickly coming into the public health space as well?
Yeah, thank you, Samir, and I'm very happy to be here. I'll just take a minute to introduce what we are doing at the National Health Authority. The Ayushman Bharat Digital Mission is out to create the national health, digital health ecosystem. And at NHA, we are not only talking about government, we are also talking about the private sector. 50% of India's health records get created in the government sector, and 50% roughly get created in the private sector. Whatever government health programs, take away or from the private sector, the laboratories compensate for that in the private sector. So a lot of records are getting created both in government and in the private sector. So why is there just a outcry for data sets from the government? I think there has to be a larger discourse. The responsibility of sharing data sets should not only be with the government, it has to be with the private sector as well. And I think that is one point which I would like to raise very, very early in the discussion. Of course, we are creating the digital public infrastructure. At NHA, we are having the Abha ID for all the citizens, for the HPR ID and the HFR ID for the doctors and the facilities. And, basically we are doing this for creating an environment, an ecosystem where digital health transactions take place. And we feel that the transacting object in these transactions is the electronic health record. So maybe we also need to look at how much of our total volume of health records is actually electronically available. Of course, the digital mission is pushing the whole health ecosystem towards creating more and more electronic health records. So without the electronic health records, the discussion around data sets and interoperable data sets is pretty futile. I think till the time we have these data sets handy, this discussion has to probably factor that in, and we have to ensure that it's a coming together of all the stakeholders into contributing these data sets and using these data sets, as was highlighted by the presentation by Karthik here, around the principles of AI and the involvement of stakeholders during this discussion. At NHA, we are ensuring that our whole approach is citizen-centric, wherein the citizen is in control of his or her health records, and the consent of the citizen is quite central to our architecture. And the recording of this consent during this whole transaction is something that which Samir talked about, creating, having a system where we have evidence of a transaction taking place, of logging these, all these consent artifacts. So that is one point, I think, where the digital mission is trying to address this problem. I think there is a lot to be done on the regulatory part. DPDP Act has probably helped us, getting our basics right, but still, when it comes to privacy, the policies around anonymization, creation of data lakes, all these policies are still under preparation. And at NHA, we already are talking about creating a data lake, and we are formulating this policy around anonymization. But I think all of us as stakeholders, as thinkers around AI, as votaries of AI, we need to move quickly around formulating these policies, because without these policies, and their applicability equally to government and private sector. I keep repeating that because somehow I feel that the whole onus of sharing the data sets today seems to be on the government. So I think I'll stop there about the initial part. The government of India very recently has, during its presidency of G20 presidency of India, we went ahead and we had the global DPI repository, which is available online. The Ayushman Bharat Digital Mission in itself is is a DPI. We are offering it, to the whole of the world. So I think there needs to be more discussion around it, around the whole need for digital public infrastructure. Thank you.
Thank you so much, Dr. Vasant, as usual, to the point. And in fact, you snatched one of my questions, which I had for the private sector players, as to why are we expecting always the government to share the data, and why can't the data available with the private sector also be shared in the public? Probably we'll come to that in the end if we have time. But I think you raised very, very important aspects, which probably were a part of Dr. Madhukar's presentation as well, in terms you are creating a continuum, as we understand with the ABHA. You are looking at making digital footprints in terms of availability of data points, and you talked about interoperability, which comes automatically with these building blocks. Excellent. And then, of course, a very important point you raised was the human-centered design and the patient being, and that was one of the points we were discussing with Mona also, right? She was mentioning that, consent, when we look at consent, we keep taking consent from the doctor. Nobody talks about the patient whose data actually we are about to share. So great points. Mihir, I'll move on to you, you being the scientist in the room, and we understand the kind of path-breaking work which, Vadhwani has been doing with the government at one end, and also, building that core infrastructure for digital health as well as AI in India, very specifically. And we've seen a lot of your work happening on ground. You've been able to create those use cases, from public health, and being able to moving towards creating at least basic data sets availability with whether, for TB, the field lead was there. Then you had the anthropometry, research which has been done. And I'm very specifically coming on to, how much of this, when you think, is applicable to the global south, and how much of effort and how much of potential investments start playing up, when you look at creating this kind of an infrastructure, institutional infrastructure, in terms of data sets, in terms of building those algorithms, looking at those use cases, and how much of it you think, and I'm coming to your point which you mentioned last time in June proceedings, that the sensitivity and the specificity vis-a-vis, the coverage aspect of the availability of data, and with the new technologies coming in, where probably we are looking at smaller data sets being used to do larger pieces of work. Where do you think we can go forward from here in terms of spending lesser money, being quick on adoption of technologies, and being able to demonstrate these use cases which you've been working on for so long? Thank you.
Am I audible? Hello?
Yeah,
Yes, fine. Yeah. Oh. Hello. Is this fine?
Yeah, it's fine.
Okay. Yeah, thanks. Thank you so much for the lovely introduction. So one thing I wanted to mention is that a lot of the technology in machine learning today is developed in the West, and while we as India are interested in building our own models, especially like the larger models, there is a lot of value in using this technology and adopting it to Indian context. Now the question that arises is how do you do that, and how do you even understand whether it's applicable or not, right? So the first step is really to design a really good evaluation of these models for your context. And so what the first step should be is to, for your particular problem, is to create the right evaluation data set and to define the right criteria for evaluation. So in certain settings, you may care about standard like machine learning or statistical metrics such as sensitivity, specificity. In other more open sort of domains such as generative AI, you're interested in evaluating like on a much broader surface area. So for example, do the prompts, do the responses to prompts make sense? Are there hallucinations and so on? So the first step really to like define your evaluation criterion. And this often requires the data collection, data curation. It often requires understanding the problem really deeply, which allows you to really get that in place. And then one thing that we've also noticed in our work is a lot of the times the data sets you try to evaluate on, or the data sets you use in the Indian context, they have varying levels of documentation and like protocol quality. So it's also very important to really have a good protocol defined properly, because especially as machine learning scientists, one thing we want to know is if the model breaks, if it goes wrong, why did it go wrong? And you can't do that unless you understand the data deeply. And to understand the data deeply, you need both a documented protocol, and you need to work closely with domain experts such as public health folks, doctors, and so on, to identify what each error means, right? And then when you come to, for example, these modern neural networks, one fantastic way to really use them is to import the neural networks, the base model from which is often high quality open source models, and do what's called fine tuning or domain adaptation, where you sort of tweak the model based on a smaller high quality curated data set that you've collected to sort of adapt it to your problem of interest. Now here again, what happens is, what we notice is that high quality curated data with the human in the loop often is much better than curating it on like large amounts of data where you actually don't understand the quality. So quality control and documentation again is super important here. So the fine tuning is maybe an algorithmic technique. We also have sort of curation from the public health lens or like from the medical lens, where a domain expert actually helps you curate, helps you understand, oh, this data looks good, but actually there are so and so errors which you might not have sort of realized as a machine learning person. One very interesting example that comes to mind is our work with the ASHA chatbots that we have. So this is a partner to the ASHA worker, the front-end health worker, that helps her answer sort of questions in her day-to-day, curating, sort of pulling answers from multiple documents that define their protocol. So one thing we noticed, so we use both the translation model as well as a generative model. Translation sort of converts their input into English, and the generative model sort of answers the question and then translates back into the local language so the ASA can understand what's being said. Very simple things. So for example, in a standard translation model, language is more formal. There's a better understanding of what translation looks like. But when you go to sort of the grassroots, the language changes, the dialects change. We noticed that the model was translating Asha as hope instead of Asha as Asha worker. So like small things like this really can break your flow if you're not careful. And so I think at the end of the day, just like understanding how to sort of fine-tune the model for your context really is the key.
Thanks, Mihir. I think that was pretty insightful in terms of from the tech perspective. I'll quickly move on to you, Joe. You work in the domain of mental health, which largely is still a taboo. People don't come out, right? And therefore, probably there's a huge potential for use of technology there, right? So from your perspective, having run a very successful startup in this space, in this niche space, if I may call that, what's been your experience, and how do you think we can make this more accessible and more affordable, as part of public health, as part of also at the ground level, right? How does it work there at that cutting edge, if I may call so?
Thank you so much, Samir. Visa is today the world's largest and #1 mental health chatbot. So we've been doing this for 8 years. We started out actually in Aurangabad, Maharashtra, doing rural trials in 300 kilometers around it. And we've sort of finished our journey doing a RCT now and a clinical trial again back there after 8 years. But the journey went from saying we can possibly solve mental health. In 2016, we realized we can possibly solve global mental health with AI. Because people open up to AI much, much faster than a therapist. And even if you can screen people for mental health, there is no therapist coming. So we first used the AI to detect whether somebody was dealing with depression using the movement of their phone. But none of them got any therapist access, only antidepressant medication prescription. What's the point? So if you're going to solve it, we realized, then our journey went to saying, okay, we're going to prove it with our own data. So the data came from 6.5 million users now globally from 95 countries, 1 million of which are in India. But all of that is still a high resource language because you're in English. And with that, you prove, you take your NIH grants. Yes, there is no funding in India, but Indian companies are getting funding internationally and proving their impact. So you get all of these grants, you prove it with NHS, government of Singapore uses it, all of that. But for the last 2 years, especially after the advent of GenAI, we've come back to India. And with GenAI, we've been able to figure out how to use it safely, privately. Anyway, we figured out anonymity and all of these clinical safety, DCBO 129, all of the NHS standards anyway. So when you come back to India, you have to apply that back in India. But you have to do something else. So that depression anxiety chatbot becomes man ka coach but le soch. So you have to, you have to really co-design it. So everything we do now is a co-design with an NGO that is working with this vulnerable population, and the GenAI is being co-designed. And you realize when you talked about fairness, it really brought to me that the kind of unfairness we were seeing was, you talked about the way it talks, right? GenAI will talk because a lot of what written Hindi is in a very written Hindi language. And Hindi is not really a language. All these dialects, they call them, are the real languages. Hindi is only 200 years old. So all of that Braj Bhasha, Bhojpuri, the dialects as they call them, that is how people really speak on the ground, right? Not the way we are taught to read. And that becomes very unfair to a person. So you have a Hindu child and a Muslim child, they're talking very different types of Hindi. And if it is not understanding one or the other, you're being unfair based on that background. So all of our co-design labs are about making sure that when you're talking your man ki bhasha, it has to be really able to understand clinical safety to detect that you're being suicidal at that time. Because the chance that AI is not working can be a life not saved. So it's a lot. Sorry, I'll stop here, but this is our journey.
Thank you for being emotional. I think it was coming out very clearly from your piece, right? And then you, I think, touched upon a very important aspect of, the interconnect between technology and the clinical protocols and setting up those in place and the processes being in place to be able to support the support mechanism which takes on the findings of the technology, right? Thank you so much. I'll quickly, sorry, I'm referring to my notes because we have got a huge panel. 10 of us, so probably it's difficult for me at this age to probably remember everybody. So Ankit, I'm moving on to you. GPAI has been in this space probably for the longest duration of time. And you again have worked not only in the private sector, but successfully being able to implement projects in the public domain as well with the governments, right? And you have a huge diverse experience of having probably worked in 100 countries now?
Yeah.
Yeah, great. So, from your experience and from your global experience, where do you think that very specifically in the radiology space, the models which you developed, how much of them are scalable? How much are they cost effective? And where do you think is the space for being able to use them in the public health? Because that's where the scale for your products is, right? So is it affordable by the governments, and how do you make it affordable for the governments to be able to adopt such technologies?
Right. Thanks, Samir. Talking about our experience, we have been sort of able to deploy these models in over 100 countries, over 2,000 sites. And coming to the generalizability aspect of this, right? What we have seen is that, taking an example from Dr. Karthik, right, gender inequality, for example, what we saw was that for a particular disease, if the same amount of men and women have that disease, lesser fraction of women will reach hospitals and even lesser fraction will reach an X-ray room. So that bias is there in the data when you are training the algorithm. So one of the findings that we had on TV was that the algorithm was getting confused by the breast shadow on the chest X-ray. And we have been working with on foundation models in some years, and we have reached a stage where we can instruct the algorithm to generate a chest X-ray with a nodule of a 45-year-old woman and compensate for that lack of data through generative AI. So the technology can, get biased because of the biases in the society, but the same technology can also be used to tackle those challenges, right? Similarly, what we have seen in lung cancer, for example, right? In the global north, a nodule on a chest X-ray can mean lung cancer, but in the global south, a lot of these nodules get confused as tuberculosis, and a lot of patients who are actually diagnosed, who are actually having lung cancer, are misdiagnosed as TB patients and are on that treatment for years before the situation becomes really bad. So again, there are multiple such subtleties that we have learned with our experience on over 100 countries, and we have been able to bake those subtleties into the algorithm today. Taking another example, the regulatory point that Mr. Bhagat touched upon, right? When I go to a US or a UK, the first question they will ask is, these hospitals will ask is whether it is FDA cleared or not. I don't think anybody is asking that question on ground in India. So yes, we need to have regulatory bodies. For example, it should be, you can only use algorithms which are cleared by CDSCO or evaluated by ICMR, but we have not seen that question coming from on ground. So there is a lot of awareness that also needs to be taken in. We have been working on, what we have seen is that in countries like India and Southeast Asia, the surveillance model has been very, very successful. In fact, we ran projects with the government of India in some pilot sites in Baran, Rajasthan, a couple of districts in UP, and with BMC in Mumbai. And we were able to show that 25% more TB patients are detected if you run AI on a surveillance mode, not in TB screening programs, right? So basically, patient is coming for cough or pneumonia, and he or she has signs of TB, which will be detected 1 year later. by that time, the situation will worsen for him or her, and I mean, it will also like sort of communicate to a wider section of the society. Those pilots had been successful, and what we were hoping for is that now we can actually scale that model across all districts of India, and our estimate is that we can detect at least 500,000 more TB patients annually if we run AI on a surveillance mode. So those are some of the learnings that we have had. And about scalability and security, obviously we have to have regulatory bodies, but institutionally as ourselves as well, we have implemented some techniques where like a certain % of our scans that are being read by our algorithms on a daily basis would be reread by radiologists, right? So that we are able to capture model drift, because the model remains the same, the data might be changing, right? So, whenever we see like sort of some drift happening, I mean, we will retrain our algorithm, or we will try to really go deeper into what is the issue with that data. So, yeah, those are some of the learnings that we have had, and happy to elaborate more, but yeah.
Thank you so much. Thanks so much. Dr. Mona, I'll move on to you. You are the sitting on the hot seat, I think, because we've been talking about regulatory frameworks and ethics, and you've been working in this space for quite some time. So just wanted to quickly ask you, where do you think we are, and what do you think is lined up for us when we look at, Ankit mentioned about, let's say the FDA and a parallel of FDA, or let's say the European AI Act which has come in. Are we looking at something like that coming up in India? And can we be looking at focusing on a global south and looking at probably more of a validation and a regulatory framework which can be used by other countries going forward, because it's a huge investment which happens at the institutional level to be able to bring these up, right? And second, attached to that was, how evolutionary do you think this needs to be, because technology is changing extremely fast. Within 6 months, 8 months, we are looking at new technologies coming up. How evolutionary do you think this should be, and are we working towards that or not?
Let me just get back to you on, since I've been on the ethics committee, and we have learned a lot working with Anurag. We were probably the first group that had actually validated the diabetic retinopathy private models and successfully implemented in Punjab in one of the aspirational districts. It was a landmark study. So coming from that background, what we realized as we were going forward, we have no regulatory network. Health being a state subject, it is up to the states how it goes. So there was a huge gap when we started and how we implemented and what was the result. So I'll just split it into 2 parts. One is the regulatory, since the research is still in the nascent stage, ethics has come into focus only now. Ethics is the last word we actually had when we were in the medical college or when you're in the technology field. Ethics was the last word. It is only when you have used the word responsible AI that now there's a huge push towards ethics. So there's no research in ethics, and we are still at the baseline. So at this point, your regulatory framework has to be adaptable. Since it is such a turning rapid pace, and a lot of AI startups are already there, it has to be adaptable, and going forward, based on our evidence that we are getting, those need to be modulated. We cannot take whatever is acceptable in the global north, that is not going to be applicable in global south. It has to be adapted to our settings. So that is where India can take the lead. And I think NHA is one of the most, I think it is really positioned quite well, considering it has actually laid the baseline where you already have the EHRs and all these interoperable methods are already there. So that is one good thing I feel that India has done in the last, and it can be taken at scale. Second, I will now come to the ethics committees, which are actually, you can say they are where we are coming at the academic. I'll talk at the academic, health systems, and the public awareness. At the academic level, we have the ethics committees. So the general ethics committees have no idea about how to take on. Sitting on the ethics committee, I have been on the ethics committee at PG, I have been on the ethics committee at the IT. We need interoperability. Ethics committees at medical colleges will need data scientists and legal experts with tech. So those need to be defined at this level. You cannot have general ethics committees. You will need to have specific, like we had stem cell committees. You will need specific subcommittees on AI ethics who are going to do it. And you will, since we are going to be working with health systems a lot, you will need government policymakers. In the health systems, again, you will need a continued program, because many of these problems are people at the government level do not really understand. There's a huge push toward, at the digital level, but people who are going to be implementing it need that continuing program. They need to understand what is the procurement process. Suppose a company comes to me when I'm sitting in the seat. Do you have the sensitivity and specificity? I think your AI actually said about validation. That is exactly what we did when we validated these DR platforms. We actually looked at, we said, okay, you give us your sensitivity and specificity, we will validate it in the real-time settings. And the biggest flaw was they had tested most of their models in tertiary care settings. They were not ready for the public health settings. So that was the second. Last is public awareness. You go, you will get the consent. We are too simple. We don't even understand data. So you need to have this, I think, since the generation next is actually so, they know what data is, but people who are in the rural settings, they don't know what data. They are so simple. They will say, oh, it's a machine. They have that lab thing in mind. Acha, lab say, aisa hai. The lab will say, give it, and they'll be very happy with that. But they really do not understand what is data security. So we will have to run data security, data campaigns at the level, national level, so that they are aware what they are signing for, how their data is going to be used. So these are the three contexts when we say regulatory is separate, but at the level of the ethics who are going to be the applicants, we need innovation hubs, validation centers, and it has to be housed in academic institutions, and centers and a separate department of medical ethics needs to be created with a specific AI ethics and this thing where you have policy, data science to be together. And if unless until that is developed, we will still be struggling across how do we implement it. And of course, a validation mechanism has to be developed. So having said that, I think that is where we need to focus now. Thank you.
Thank you so much, Dr. Mona. I think clearly, I think we got a lot of work to do there in that space, and probably that could be one of the inputs which we can probably take back to the GPAI forum, right, in terms of the institutional framework which you said needs to probably be set up first, and then we can look at the actual frameworks in terms of evaluation and validation, right? So probably setting up that rightly, and I think that's what even Dr. Karthik mentioned when he talked about the AI playbook and the AI life cycle. That's a huge piece in that, and probably we need to solve this puzzle as we go forward if we are looking at scale coming in. Anurag, I'll move on to you. I can't see you, sorry. Okay, thank you. You are in the process of setting up probably the most state-of-the-art setup in India, right? And having had the privilege of see it coming up, it's very exciting. So from your perspective, as you are setting it up, what are you looking in terms of the next generation of innovations and technologies coming up? And very specifically, looking at the community and the public health focused technologies.
Thank you very much, Samir. One of the pleasures of going last is that you have got wonderful points from previous speakers to build on, and sometimes wonderful lines like Joe said, "Man ka coach badle soch," and the fact that there is no one language, and these are real challenges. And I'll start by my answer by pointing out that people who need to do surveys for even companies like Flipkart realize the answer in India to a survey can be ghanta. And ghanta is not a recognized word in any particular thing, but if you want to use AI, you have to do it. So what is the challenge when you look at state-of-art systems today available? That you can do it. There are two directions to this. The first part is the huge data piece that I think Dr. Garg, Dr. Dapa both spoke about. Until you have electronic health records, you are not going to really move forward. And this is something both public and private will do. But here comes the next part. Even if you had electronic health records, how will you extract the data? One entire major direction of work for us is an extraction of such data, because the reality of India is all the note that regarding all the medication will be in the other note section. It won't be on the drop down of the drugs. And this is something I know from previous experience in 2012, where we deployed e-health centers with Hewlett Packard, in a shipping container, everything on the cloud. We hit 5 million people. We went to Bangladesh, we went to Bhutan, World Bank, Philippines. But when we look at the data, it was very trivial, right? A few diseases and symptomatic care pretty much took care of 90% of things. So one is, given electronic health records even at scale, how would you meaningfully extract data? And we find that current generation large language models aren't ready. But the brilliant part of it is that open source deployable tunable models have now been given. I think as a community, we must be very clear that if we want to do things for India, we want to do things in a setting that are useful to all, these have to be models that we tune and train on our data, our contexts, which means we start with them. And I will not name companies. I don't want to promote any single company, but the open source world, even in the domain of, let's actually call them large multimodal models, because language is just one part of it, that is what excites me. And the other brilliant part is that everything is so fresh and young, that young kids playing with this have as much a chance to do well as people with great experience in computer science. And last time I looked, if there was one thing India had plenty of, was young, interested, enthusiastic kids. So to me, it's not about Ashoka, it's not about my center. If we come up with a symptom solving on one side, what Basant talked about, the electronic health data issue where both sectors participate, and creating a pool of people who are willing to use multimodal data. And I find Indian companies are very willing. Recently, a company called Goki is opening up their APIs on our campus for young people to play with. So this is the experiments India must run, always keeping the core of GPAI responsibility. And one last word, very important along what Mona said. Mona, New England Journal never opened another specialty journal in all these years. Finally, it opened the NEGM AI. I think the departments India will need are departments of medical AI. And it won't be run by physicians alone, that's critical. And the other thing about consent, it is never consent, it is informed consent. Where is the information? In fact, who has the time to give information? But language models following playbooks and scripts can actually provide information, engaging the deepest of people whose data we take. So very long answer, but I hope that was useful.
Wonderful. I think it was very encouraging, actually. Thank you so much for that. And by the way, you were not the last speaker. We still have Gitanjali in the room. So moving over to you, Gitanjali, because you come from a diagnostic background, represent the private sector, have worked quite a bit and quite long in this field. So from your perspective, very specifically, what role do you think private sector can play when we look at demonstrating success in public sector? And again, alluding to the question what Dr. Basant actually said, why are we always looking at data coming from the government, and what role do you think the private sector can play in terms of making this data available for larger use?
Sure. So I'll try to keep it brief. So the problem statement, we worked for the past 8 years into antimicrobial resistance. You know that judicious prescription of antibiotics is not followed, and it's a very difficult problem to solve. And the niche area that we have chosen is wound care. And it's, in India at least, there's very little knowledge. There are different schools of thoughts. And antimicrobial resistance is a very big problem. You need to target UTI, urinary tract infection, blood sepsis, issues related to wound care, and that's what we focus. And over the past 8 years, what we realized was, being a single company, we have a technology that can detect bacteria, fungus without even taking a sample. So we use photonics plus AI, which is a core strength. And we've been called in many of these international photonic conferences to give presentations in the patents and what we have developed, but then it requires huge amount of money if we have to apply the same technology in other application areas. So only focusing on wound care, maybe I can throw some challenges that we face, and it can be adopted across. We are currently licensing our technology for developed countries because we understood that it's a very difficult play if I have to go to global south. It's a very difficult challenge. You need to come with incentives like how Megha told. It has to be very attractive for the Indian community. to adopt both in the private policy level, and it's a big challenge with lot amount of money that is required. Now in US it's very simple because you have insurance providers, you need data, diagnostic tools are used, preventive tools are used, they look at the data, then only they prescribe, let's say, antibiotics or even advanced therapeutic solutions. So the first part of it in India, what we realized is there is no money in prevention and diagnostics. It's a very hard pill to swallow. I'm so happy that GPAI was able to do it because they've partnered with, AstraZeneca was one of a very good strategic partner, but not everybody is blessed with that. So we now have so we now have come with a very good solution where we have a preventive model where you can screen at the point of care at home. We have a diagnostic solution which is a core IP, and we have also combined with many of the therapeutic players so that when you approach a patient at their site, you can give starting from understanding how early are they to develop a wound. If they developed a wound, what has happened to the wound, whether there's an infection, whether there's a lot of blood flow, and if there is a loss of blood flow, what are the therapies that they can do there itself. And you know that all this requires a lot of data. Now this is where I'm coming to. Again, there's a lot of challenges in private players sharing the data because in US the same kind of solution, the BARDA has given $100 million grant, and the company was just doing research for the past 10 years. They're happy to share the data, and it's predominantly on wound care, which is for burns and traumatic wounds and how the wound healing journey has gone. But in India, you're severely constrained. And if I have to approach and tap into investor community, what sets us apart is the proprietary images we have. So as a private player, we are very much happy to share the data provided the government on a policy level understands this is a huge issue. Startups are addressing it. Let's please support them. I'm not telling give all the $100 million. Support in different milestones. Let us prove to you that we can bring in the impact and the change that the community needs. And we're happy to do it, taking it forward. And one last point if I can add, again, if India has to develop our own regulatory pathway around this, we are already spending millions of dollars, looking at EU MDR, looking at FDA, looking at the cyber security and other aspects of it that they're doing. If we can adopt something that's on the similar lines, we can save funds as well, and we can develop something that's more robust and that can cater to the global, South as well, not just India. I hope I answered.
Thank you so much, Gitanjali. I think you made us feel your pain. Everybody felt your pain in the room. Thank you for that. I think we are quickly coming to a close of the discussions, and I'll quickly move probably to the experts. I think, and I realize that all three of you sitting here probably have about 70 years of experience between. I'm not looking at the age, and I don't want to predict that, but I think more than 70 years of. I was talking about the overall experience, and I'll move on to quickly to you, Dr. Madhukar. You've heard the panelists, right? And we've heard the private sector perspective, and we've also heard the government, and we've talked about the regulatory framework, which you were talking about, interoperability. Any last summing points from your end? How do you think we should be looking at tackling all these three issues which we talked about going forward?
So tackling the three issues is easier said than done, frankly. When we talk about and I won't say that work has not been done, a lot of work has been done. If I talk about the issue of data availability, data accessibility, data standards, then NHA is doing wonderful work. And if that is to be implemented as and when it gets implemented, it will be creating a wonderful ecosystem as far as data is concerned. First of all, we have to understand that. As far as the issue of regulations are concerned, there is a common understanding and a common belief that yes, we read a regulation. And the regulation and the regulatory framework is not just in one dimension. Something has to be in IT, something has to be in medical sciences, and something has to be as a as an overlap between them. Eventually, it's the bodies and the organizations which have to be seeing who has to do what. And it's not just one person's baby, not one organization's responsibility. As far as the third element is concerned, that I understand that India will be a great platform for the launch of AI in health. And that is because of the inherent requirement and the core strength which India has. And if we see that what are our health goals is firstly is availability of healthcare, second is affordability, and third is accessibility. And if I talk about integration of AI in different elements of technology, for example, if I take telemedicine and AI, which we have put together, then it addresses all the concerns. And it helps India to attain those goals. And as I've already spoken, that we have the huge data sets which we are there to tap. But again, the steps are already there which we are discussing. We have a young people who understand technology. We have technology which is available, but then again we have to adopt it from the Western context to the Indian context. So these are some of the areas which is going to help. And last but not least, ethics has to be a part of a regulation also. That I feel eventually. So that's what I can add as a, as a summation of what I feel.
Thank you so much. Dr. Basant, moving on to you, any last comments you feel? How do we go forward from here?
Yeah, thank you. I think I'll just invert the argument which I started with, that it is equally the responsibility of private sector, because it is very important to invert the argument. I think AI is a very good use case for forcing the private sector to join interoperability, right? So it's not that I'm not a naysayer. It's just that I wanted everybody to think about it. But I think AI is a very good use case, wherein and government of India has already taken a lead in digitizing, in adopting the APDM interoperability standards, and I think it will force the rest of the ecosystem to follow and join it. I think one more thing which I would like to really mention is that today the digital mission is only creating the basic infra. It is for the private sector to innovate and to use that infra to bring out more value-added applications, services, and I think that is where I was very happy to hear what Ankit and Gitanjali were talking about. Government does not aim to do everything by itself. We are really looking forward to all the people in the private sector to innovate. I think there is a case for how we support the early movers of AI so as to strengthen the whole ecosystem. Thank you.
Thanks, Dr. Basant. And I think I stand in testimony to what you said in terms of probably you are the shining example in India of having set the technical sandbox, which is being now used by the private sector to validate. And that's exactly what we are looking at being replicated in the AI. And I agree with Dr. Mona that probably you are the institution which would be taking a lead on trying to replicate that for the entire technology space. But we can leave that for another day in terms of discussion. Moving on to you, Dr. Karthik, what are your key takeaways and what do you think can we pass on as an informed, thinking from this group back to the GPAI forum going forward?
Firstly, thank you all so much. I think this has been a very learning experience for us at GPAI. We've been essentially trying to get a variety of stakeholders. I think we've also felt there is a need for more stakeholders. So that's the first one. I just want to kind of leave with three broad thoughts. First, taking on what Anurag talked about, the concept of open source, standards-based digital solutions that we've done. Can India lead the path from the global south in coming out with these open source AI solutions? I think that's something which has been one of the key takeaways that I've had. Second is, of course, is on the fact that, I kind of, when I looked around the group, we now have a variety of stakeholders coming in, but what about our education and our capacity building? The fact that we need interdisciplinary education. I'm actually really fortunate that I'm a physician by training, but but actually went to got trained as a data scientist in the US. But so that's one of the reasons why I didn't talk about anything in AI, because I've not done any AI research in the South. So most of my research is in the global North. But so what we really see here is a very vertical, siloed education system. So whether you go to medical school, an IIT, or an engineering school, I think the good part about AI is it's not just for a physician or an engineer, it's also for a social scientist. There's also space for an anthropologist. So essentially, AI is one space wherein not just the private sector and the government, but also people from around a variety of stakeholders can come in, and most importantly, the civil society, citizens who have an extremely important voice to play. So I think, therefore, what I feel is, I think as GPAI, and especially for the organizers, we are extremely happy that we're able to capture a very diverse arguments, diverse perspectives. And I think essentially what we want to do is, in terms of the next steps, think about creating this playbook on how do we capture all these perspectives in a typical AI life cycle. And I really want to thank all the participants, as well who've been a part of this interesting conversation. I think we may not have time to listen to your questions, but we have the experts here, so please feel free to have great conversations. Thank you, Samir, for great moderation as well. Thank you all so much.
Thank you, Dr. Karthik. And before we leave the room, I know you had quite a few questions in the audience, and we also had a couple of them, but unfortunately, because of the paucity of time, and like Dr. Karthik mentioned, I think we can socially engage after this. But before we leave the room, I just want to put a vote of thanks for Ananta and her team. Ananta, can we have you? Yeah, okay. Thank you. Thank you so much for organizing this. It's a huge effort, I'm sure, getting all of us with the different sets of times and organizations. And thank you so much for organizing this for us. Thank you.
Thank you, Mr. Kanwar, and thank you to all our esteemed speakers and panelists for your invaluable contributions. Your insights and experiences are crucial in shaping the future of AI in global health and will greatly contribute to the platform of the Global Partnership on AI. It is through gatherings like these that the unique perspectives and challenges of the Global South are captured and represented at an international level, ensuring that our collective efforts are inclusive and impactful. I would now like to invite Mr. Rajneesh Kumar, CEO, Director, Capacity Building and Finance, NEGD, Digital India, to kindly felicitate our esteemed speakers. Please join me in thanking Dr. Karthik Adappa. Dr. Karthik Adappa, Regional Advisor for Digital Health, WHO. Dr. Basant Garg, Additional CEO at the National Health Authority. Dr. Basant Garg, Additional CEO at the National Health Authority. Shri Madhukar Bhagat, JS, Ministry of Health and Family Welfare.
Thank you so much.
Mr. Sameer Kanwar, Director of Digital Health, India and South Asia, PATH. Ms. Jo Agarwal, Co-founder and CEO of Visa. Mr. Mihir Kulkarni, ML Scientist at Vadvani AI. Ms. Megha Chaudhary, Advisor at Brainsight AI. Dr. Anurag Agarwal, Head of the Koita Center for Digital Health at Ashoka University. Dr. Mona Duggal, Assistant Professor at PGI Chandigarh. Dr. Sanjay Sareen, Vice President of Access at FIND.
Do you have a card? Okay.
Mr. Ankit Modi, Head of Products and founding member at Cure AI. Ms. Gitanjali Radhakrishnan, founder, CEO, and MD of Aduvio Diagnostics. Thank you, everyone. I request all speakers to kindly stay back for 5 minutes so that the social media team can interview you. Thank you.